flexion over that border of the pancreas. And then we just take the lateral attachments and attachments to the greater omentum. But the answer is yes. We do that systematically because I don't want to do an anastomosis and then realize that I don't have enough length and then go back to try to mobilize more. That's something that I try to avoid to the best of my ability.
Wonderful. Do you have any tips to staple very low in the pelvis?
Well, I mean, I think it's challenging. I think you have to, if you want to staple very low, you have to mobilize very low. Sometimes you have to get almost to the intervertebral space. And you can do from above, that's dissecting. You have to use your retracting arm, which is the one I place most laterally in the left side, to retract whatever, the seminal vesicles, the bladder, the prostate, anteriorly, or in the female, the vaginal wall. And then again, I tend to come from the right with the stapler. I don't try to go horizontal, I go vertical. The rectum is round. It doesn't really matter the orientation of the stapler. And I find that coming from the front to the back is easier. Sometimes you use the stapler to push the organs a little bit away as you come down. You have to realize that when you are very low, the tip of the stapler hits the coccyx. Because of the stapler has a centimeter or two where it closes but doesn't staple or cuts, you're always going to need to have more than one fire. For that second fire, you have to angle the staple a little bit and not to come in a perfect front to back, 180-degree approach. You have to just tilt it a little bit to let the tip of the stapler go through the part that you haven't divided and then divide that part. I think you can go quite far. I mean, there are going to be some cases that you just cannot staple. And those are the cases where you have to go transanally if you want to do a coloanal. Some people might argue about that and prefer to do an APR. But occasionally we do coloanal. You just have to go transanally, see your distal margin under direct vision, and then divide the distal portion of the rectum at the level of the sphincters transanally under direct vision, choosing your distal margin wisely. So I think sometimes you have to understand that, just trying to get the stapler in a case that, the tumor is very low might compromise your distal margin, and it's better not to do it. Just do a coloanal. You want to do a sphincter preservation procedure.
Wonderful. What percentage of your cases, I think this implies, what percentage have covering stoma?
Well, as I say, of the patients who receive locally advanced rectal cancer who receive neoadjuvant therapy and require a complete mesorectal excision, I would say 100%.
Okay. I think we heard your opinions on this, but the question is, what's your opinion about robotic TME?
Using the robot transanally, I mean, I think, as I mentioned, we don't. I think for most cases that when the case is so low that in my hands needs a coloanal, the dissection is very low, so the TME's platform will occlude the area where I'm going to be working. So in other words, the area where the robot or the laparoscopic through the anus will be effective, it will be covered by the port that we have to use. So I come from above as far as I can. Sometimes I start the operation from below if I think the intersphincteric plane might be involved. But I don't use the robot for TME. I use it for the procedure where I'm going to do a coloanal, hands-on coloanal anastomosis. We use the XI platform transanally to do TMEs. It's feasible. If you can do it to do TMEs, you can do it to dissect the mesorectum. But I don't think it's necessary. If you are going to need to work from the pelvic side, I don't think it's necessary to use the robot to do a TME. The portion that I need to do through the anus, I just do it using conventional transanal instruments because it's usually quite low. I don't know if I made that clear. I think the robot can be used, but normally I don't use it for that purpose.
Okay, wonderful. How many cases do you think are necessary to get to the plateau of the learning curve for normal LARs?
Well, I think we look at that here at our own institution, and what became very clear is that there were two of us that started just about at the same time, And we have a kind of probably a longer learning curve. When we started to train other surgeons after I came here in 2012, the learning curve was much faster. I think with 25 cases, I think people can get very good at these procedures. I think probably that's a reasonable number.
Okay. What's your routine for ileostomy closure, previous exams and time?
Again, now that we used total neoadjuvant therapy, patients have received all the chemotherapy before we do the total mesorectal excision. We usually close our ileostomies approximately 12 weeks after the TME procedure. Again, in that interval, the patients don't need to receive any more chemotherapy. Usually, we do a gastrographic enema. Sometimes we do a flexible semidoscopy. Occasionally, when the patient needs a CT scan for other oncological reasons, we do a CT scan of the chest, abdomen, and pelvis with rectal contrast. I think any one of those tests, will be helpful.
When will you do lateral pelvic node dissection?
That's a very good point. There is a lot of debate about it. We don't do it routinely. We have reviewed our own experience as part of a big consortium, including a number of institutions from Japan and Korea, the Netherlands, other countries, Australia. There is a relationship between the size of the lateral pelvic lymph nodes at baseline and the probability of being positive. And also there is a relationship between the size of the lymph nodes after neoadjuvant therapy and the probability of being positive. If the lymph nodes were more than 7 millimeters at baseline and they do not decrease in size to 4 or less millimeters after neoadjuvant therapy, we do a robotic lateral pelvic lymph node dissection. And again, we do a number of cases every year. There are not that many patients that meet those criteria, but some patients do, and we do the pelvic lymph node dissection as part of the TME in those patients.
Wonderful. You mentioned there might be some increased cost, but increased value also in robotic surgery. Have you done that analysis at MSK?
Well, we haven't done it specifically for any one of these procedures. But I think we have looked at the cost of the complications. I think what really raises the cost is are the complications. They're very expensive. And in the last few years, and I must say, it hasn't been only the robotic. We have changed a number of things. We have started simultaneously initiatives to decrease the surgical site infection rate. We have, with the help of the robot now, we have pushed our enhanced recovery programs. Again, our patients, because they have much less trauma during the surgery, they recover faster, they go home faster. We have added other things in addition to the robotic platform. All this has contributed to decrease our length of stay very significantly. And for us, bed availability is a huge commodity. Manhattan, we cannot build a hospital, whatever we want because the space is very limited and we have a limited number of beds. It's a big problem for us. So reducing the length of stay, reducing the complications, reducing readmissions, it has added significant value. And again, unfortunately, we changed a number of things at the same time, but I can tell you that the robot has been pivotal in those improvements. So that has, we can do more cases, we can do more surgeries, we use less resources. I think, things are moving in the right direction with just using the advances in many different fields.
Mm-hmm. And how do you control bleeding in the pelvis if it unfortunately happens?
You have seen that the amount of bleeding that we get is very limited. I mean, I think the key thing is to be in the right plane. If you're in the right plane, you stick to that areolar space posteriorly, we don't get perisacral bleeding. There are no big vessels that they cross the mesorectal plane. If you get bleeding, you are in the wrong plane. And again, you have to control it with the devices that we have. The perisacral bleeding can be quite bothersome. When I do in open surgery, which we often do for recurrences, big pelvic centrations, sacrectomies, other things, One of my favorite ways to control it is just putting pressure and weight. But you cannot do that robotically. Well, you can to some degree. I think the main thing with bleeding is to prevent it. And you prevent it by being in the right plane and being precise. And I think that's one of the advantages of the robot, that allows you to see the plane so much better. The two places where you get bleeding in a total mesorectal excision are usually posteriorly. Here you get off the right plane and get beyond the presacral fascia and get into the presacral vein. And then in the anterolateral part, where you have the neurovascular bundles. You saw a little bit during my dissection. There is a point where you get close to the neurovascular bundle, where you get below the seminal vesicles. Anytime that you get off the right plane in those sites, two things are going to happen. You're going to get bleeding, and you're going to damage the nerves, and the patient is going to get problems in terms of urinary dysfunction and sexual dysfunction. So I think my recommendation is just to do the operation well in the proper anatomical planes, and again, follow a very systematic approach. Work posteriorly in the right plane, work laterally a little bit, then go to the front, open, come from front to the back, avoiding those neurovascular bundles to cut the lateral stocks in the right place. And I think, you are not going to see much blood.
Wonderful. What about right colons? Do you also do them robotically?
We do. And I guess that we could talk about that another day. I mean, I think it's now, I think we have learned a lot from the robot, and the confidence that we get from the enhanced dexterity to work, around structure that we were always quite concerned. All the venous drainage of the right side of the colon and the hepatic flexure, and all the branches of the Henle vein that we were always very afraid, and we never wanted to see in the past. Now we see them individually. We divide them, we ligate it, and make the operation oncologically probably better, faster, and safer. So I do it. We do all the colectomies that they are elective procedures. We do them with the robot. Right, left, transverse colon, total colectomy, total protocolectomy. We use the robot for all these procedures.
Do you always use ICG in your procedures?
I would say most of the time. I didn't at the beginning, but I don't think in our institution just using it is very expensive. We have the technology, it's incorporated into the XI. I use it quite often. I have been a couple of times where I have surprised myself and finding that I was wrong in my assessment of the optimal point of transection. It has helped me in few cases, so I use it. I use it particularly in low anterior resections after a total mesorectal excision, where you want to make sure that your conduit, the portion of the colon that you are bringing down, it has good blood supply. Even with the complete mobilization, I use it, and I advise people to use it.
Okay. How is your experience in performing robotic TME in patients with low BMI and narrow pelvis? Any specific tricks in port positioning?
Well, I think that's a good point. I mean, sometimes, first of all, I think sometimes very, very thin patients are more difficult. I find the separation of the plane, just lifting a thin mesentery from the retroperitoneal, can be harder in very thin patients. Then in some patient who has a very narrow body, it can be challenging. You have to work, just optimize the distance when you are looking from the head to the foot of the patient, how far apart you put the instruments, because you might be hitting the pelvic brim with the instrument. So you tend to put it a little bit higher and a little bit more medial, because if you put it lower and more lateral, you're going to find yourself that you are hitting the iliac vessels with the instruments that you want them to get to the pelvis. So I think a little higher and a little bit more medial, more close together to each other.
Do you consider a frozen section for assessing distal margin?
Well, as I say, when I'm doing some cases where I elect, because the patient prefers to have a coloena, and the margin is close, I start the operation transanally, get into the intersphincteric space and make sure that that space is open, that the tumor hasn't penetrated that space. Because if it has, you have to stop the procedure and do an APR. You know, in that plane, we are working inside the elevator. If you are going to do then extra elevator APR, you're going to be outside, so you haven't lost anything. And in some of those patients, occasionally, I do a frozen section to make sure that where I'm dividing and where I'm dissecting is free of cancer.
Mm-hmm. Do you prefer end-to-end or side-to-end colorectal anastomosis?
I have gone, in my career, I have used all of them. I have used side-to-end, I have used colony pouch, I have used coloplasty many years ago. Now we do end-to-end. If you use the descending colon and do a good end-to-end, I think the functional outcomes are as good as with any other technique. The operation is simpler, one less staple line, and I think it's easier to reach. Now, the premises is that you don't want to staple the mid-transverse colon to the anus because that's more muscular part of the bowel and you're going to have probably worse function. But I tend to use the end of the descending colon. That's the reason why we take the spleniflexure, that's the reason why we take the vein in every case. Because my intention is to bring the end of the descending colon to the rectum. And I think probably, in my opinion, that is the best anastomosis that we have.
Wonderful. And thank you everyone for a lot of questions. There are more than we can go through here, but I'll read two more maybe real quick to respect time for everybody. Do you ligate IMA routinely at origin, high ligation or not?
I will say yes. Probably it's not for oncological reasons. You can just take the lymph nodes and dissect the lymph nodes. But I take the left colic. So if I'm going to take the left colic, I just take the inferior mesenteric artery and then divide the bowel. I mean the mesentery there at the level of the left colic going towards the junction of the descending and the sigmoid colon. So I normally do. Now, I don't try to dissect the artery all the way to the origin, because on doing that, you might damage the hypogastric plexus and end with the retrograde ejaculation in a male. So I'm very, very careful when I'm dividing that artery to stay out enough on the trunk to avoid injury in the hypogastric plexus. At that point, still more on a plexus than a true nerve, but you have to be careful to protect them.
Mm-hmm. When do you use lateral to medial approach?
Pretty rarely. I think almost never. There have been occasionally a case that had some previous surgery, some additions, some abscess, you know, tumor that is unusual, but not very often.
Okay. If you don't have the table motion and you perform the first splenic flexure, what's your preferable rotation of the patient first?
If I'm gonna, the way we used to do it before we had table motion, again, I mentioned that before. I start from the right side. I use two arms, right upper quadrant, right lower quadrant, camera close to the belly button. And I usually use two arms for the mobilization of the colon or the takedown of spleniflexure. I just call medial to lateral. The patient is tilted right side down, approximately 12, sometimes up to 15 degrees, and a little bit of Trendelenburg. And with that position, I can do the entire mobilization, control of the vessels, both the vein and then the artery, medial to lateral dissection, takedown of the spleniflexure. And then I take the instruments out, rotate the boom, put the patient in stiff Trendelenburg, and I work on the pelvis. So that's the sequence I use.
Wonderful. Thank you, Dr. Aguilar, for your time today. And we appreciate everyone's participation on our Global Colorectal Channel webinar. There will be more of these regularly every month. And we appreciate your attention and time. And we hope to host you in our next series. Thank you very much and have a great day to all of you.
Thank you.
Thank you.